Hello everyone. Welcome to the Exercise Management for Chronic Fatigue Syndrome, the Evidence and Current Approaches webinar. We're glad to have you here with us today. My name is Tanya Hyde and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability, and this webinar is made possible through the support of the Community Gaming Grant program through the BC government, as well as through donations and memberships to our organization. Before I introduce our speaker, I just wanted to address we've had quite a few people contact us around this topic. I just wanted to let everyone know we are aware of the controversies around exercise for myalgic encephalopathy and chronic fatigue syndrome, and we're also aware of how the two diseases are both similar and different, and that Dr. Broadbent will be touching on some of these topics as she goes through a wide variety of research that is current and valid on this topic. So we just want to foster a respectful discussion based on both Dr. Broadbent's own research as well as the research that she's going to be talking about. So we're really glad you're here to be with us for this important topic and important discussion. Our presenter today is Dr. Suzanne Broadbent. She has a Bachelor of Education, a Bachelor of Exercise Science, and a PhD in Exercise Science. She's an accredited clinical exercise physiologist with Exercise and Sports Science Australia. Dr. Broadbent is currently Senior Lecturer in Clinical Exercise Physiology at Southern Cross University in Lismore, Australia. Suzanne's research interests include exercise immunology, specifically the effects of long-term training on immune function, exercise interventions for cancer, chronic fatigue syndrome, and autoimmune conditions, and cardiopulmonary exercise rehabilitation. We're really glad to have you with us here today, Suzanne. I will hand it over to you.
Okay, thank you very much, Tanya, and thank you very much everyone for attending. Just before I get started, I'd just like to sort of reassure people that I actually have nothing to do with the PACE trial. I've never been associated with that at all. I know that Tanya's received some queries about that. The research done by myself and colleague Roseanne Coots was actually funded by an Australian medical grant organisation, so we have nothing to do with any of the research that currently goes on with the United Kingdom. The presentation, I know that there are a lot of people in the audience who have CFS themselves, and I'm expecting that there's quite a few people who are also clinicians, allied health perhaps, or exercise therapists. So I've tried to focus the presentation on going over some of the evidence for exercise, I suppose, with chronic fatigue or ME, and also I wanted to lead in a bit about my research that I've done recently on intermittent exercise compared to graded exercise therapy for people with CFS. With the learning outcomes, I just briefly want to go over the pathophysiology, symptoms, some of the physiological responses to exercise, and also some of the red flags for exercise with this population group. I'm hoping people understand that some of the different exercise modalities, the evidence behind those, and possible effects on immune responses and fatigue, and also briefly want to evaluate the current CFS-ME exercise literature, and just point out that there are, plenty of areas for further research. I will refer to this condition as CFS rather than chronic fatigue syndrome, myalgic encephalomyelitis, because that is a mouthful, but also where there are some differences with the terminology. Just briefly with the background, CFS and myalgic encephalomyelitis are commonly interchanged terms, although the diagnostic criteria differs somewhat. Interestingly enough, there's been another proposed, systemic exertion intolerance disease, which was proposed early last year by the Institute of Medicine, and the focus there is probably looking at the post-exertional malaise as the primary symptom. CFS is a really complex condition. If you look at the World Health Organization classification, they have ME as a neurological condition, whereas CFS has been relegated to abnormal clinical and laboratory findings, not elsewhere classified. Neither of those descriptions really capture the severity or complexity of CFS, and we know certainly that it's not just a neurological condition. There are other symptoms with that as well. Just a review of the sort of general criteria and classifications. The older criteria sort of said that, it was severe fatigue for more than 6 months and patients had to have 4 or more of the following criteria. So sore throat, impaired memory, unrefreshing sleep, post-exertional fatigue, sore lymph nodes, aching muscles, joint pain and headaches. It's kind of been superseded by the Carruthers updates, I suppose, where really the focus is more on the post-exertional malaise as the primary symptom, but certainly looking at the other symptoms as well. So fatigue and sleep dysfunction, the neurological and cognitive symptoms, and this also includes the autonomic, neuroendocrine and immune symptoms as well. So it's probably a better classification. Prevalence, it depends very much on which country you live in and what source of information you're looking at, but it varies between 0.2 and 2.5%, and there is, quite a wide variation in the extent of symptoms with the various classifications. We do know that approximately twice as many women as men have CFS, and that's something it seems to share with quite a few other autoimmune conditions. With recovery, less than 6 to 10% of patients return to full function. Again, that figure varies depending on the sources that you look at. I've included the pictures there. That lady is Lane Beachley, who was an Australian and world surfing champion. The guy on the bike is Alastair Lynch, who is a champion Australian footballer. They're 2 examples of people that were diagnosed for years with CFS and were able to actually recover and go back to their normal sport and status. But again, this is a very, very small percentage, and we know probably the majority of people that have CFS make some recovery but don't. And of course there are a small number of people that really don't recover at all and are typically sort of on bed rest for years and years. With the pathophysiology, yes, it is complicated and it's probably multifactorial. Most of the evidence suggests that people at some stage have had a severe viral infection that acts as a trigger. Common ones that crop up are Epstein-Barr virus, Ross River fever is quite common, meningitis, Q fever. Often it's combined with some sort of severe emotional stress or traumatic event. There are some people that in fact don't have viral infections but just seem to get CFS or ME simply from having sort of really severe stress or trauma. But the immune dysfunction in response to pathogens or hypersensitivity also seems to be a growing sort of cause, and I know that in Australia we've had a lot of people that have developed CFS after being bitten by ticks or spiders. That may be something that happens also in Canada and the US. Just with the diagnosis and symptoms, it certainly is complicated because the condition's very complex and there's a continuum of often fluctuating symptoms and levels of disability. There's no specific medical diagnostic testing for CFS and ME, and it's very much medically a process of exclusion of other disorders. So typically patients have to undergo lots and lots of blood tests to sort of exclude cancers and thyroid disorders, liver disorders and so on. And often that diagnosis to get them to the point of yes, it is CFS or ME will take years and years. I think the issue is probably clouded by the overlap with other comorbidities. Some people also have autoimmune conditions on top of CFS, and some people report functional somatic or central pain syndromes. But what crops up really is one of the primary factors is this post-exertional malaise and exercise intolerance. Some of the associated conditions, and there are a lot of them, in the terms of cardiorespiratory conditions, postural orthostatic tachycardia syndrome or POTS occurs in 25 to 50% of CFS cases. Orthostatic hypotension, autonomic dysfunction, vasovagal syncope are also quite common, as is dyspnea or breathlessness. With haematology, anemia or iron deficiency is also relatively common, and that seems to go hand in hand with abnormal red blood cell morphology. With immune function, there's a lot of quite recent evidence out there that there's a decrease in natural killer cell activation. There seems to be a lot of conflicting evidence with the cytotoxic T cells or CD8, whether they're actually suppressed or not. Seems to be decreases in T helper cell responses and increases in inflammatory cytokines and markers. With neuroendocrine dysfunction, again, relatively common that people will have a dysfunctional HPA axis, and that can affect cortisol production that's associated with stress responses and immune function as well. With the genetic conditions, there's been quite a bit of recent research looking at the upregulation of genes, pain receptors, and for sympathetic nervous system activation and metabolite detection. There seems to be an upregulation of those genes with CFS and ME. With musculoskeletal conditions, fibromyalgia is incredibly common. Somewhere between 50 to 70% of people with CFS will also have fibromyalgia, and even with children that have CFS, 30% of those show those sorts of symptoms. Arthralgia and muscle weakness are kind of included in that musculoskeletal category as well. With the metabolic and mitochondrial conditions, this is quite interesting because there seems to be a lessening of oxidative enzyme activity and a greater reliance on anaerobic cell metabolism. Some of the proteins and signal transduction molecules within cells seem to be altered. AMPK phosphorylation, that's an enzyme that's involved with fatty acid oxidation, and oxidative metabolism seems to be downregulated. And there's quite a bit of evidence that cells or tissues will undergo oxidative and nitrosative damage as well. With gastrointestinal conditions, irritable bowel and bladder syndromes, nausea and bloating are fairly common. Intolerances, again, some food intolerances, intolerance to chemicals like, say, chlorine or other pool chemicals, sort of amplification of pain in response to light, and multiple allergies are also common. With the central nervous system, recent evidence has shown that many people with CFS have a decrease in grey matter and cerebral blood flow, which may very well be linked to some of the cognitive issues that they have. Migraine and headaches are quite common, and depression and anxiety. And I guess looking at some of the cognitive issues, poor memory and concentration are extremely common, as are sleep disorders, and these cognitive perceptual impairments where pain and fatigue might be amplified are also pretty common. Just with the treatment approaches to date, there's quite a lot of evidence for things like specialist medical care being beneficial, where people especially with multiple conditions have to have medications that need to be balanced by their GPs. Cognitive behavioural therapy, there's as we know, quite a lot of evidence out there that this is beneficial, and yes, that's often been sort of lumped in with graded exercise therapy in some of the big trials. There is a lot of evidence that graded exercise therapy works for some people with CFS, but obviously not others. Probably less evidence that adaptive pacing therapy or the energy envelope approach works, but again, there haven't been a huge number of studies that have looked at that. Quite a few recent studies have looked at multidisciplinary team approaches, and that seems to work well, provided that there's ongoing sort of counselling and communication and follow-up with CFS clients. Probably less evidence for meditation and relaxation therapy, although anecdotally a lot of people say that that helps them. Nutritional therapy, there's not a lot of evidence out there that that actually is beneficial. Antidepressants certainly work for people that suffer from depression, but may not work for everybody. Sleep therapy for people who have sleep disturbances, there's evidence that that is effective, but certainly for alternative medications there's not a lot of evidence that it works. And the problem with all these approaches is there are often different outcome measures for all of them, and that makes comparison quite difficult. Also coming out of the evidence, I guess with the treatment, what the approaches seem to favour is that activities need to be sort of paced with respect to the physiological and mental limitations. With a lot of the guidelines, I'm just quoting the NICE guidelines here, the heart rate limits from all the evidence suggest that somewhere between 50 to 70% of heart rate max is a good sort of set of limits, I suppose, for people who want to be physically active. But again, there's a lot of variation there, and probably the clients that have less symptoms would be able to be physically active at a higher percent of their heart rate. The aim of all the treatment approaches, though, is certainly to try and reduce the symptoms and enhance wellness and quality of life. Behaviour change and acceptance is quite important. That's really the foundation for the cognitive behavioural therapy. But continuity of care, just treating someone in isolation as a one-off is not going to be effective. So that continuity of care over time has shown benefits. I'm just quoting the fairly recent Cochrane review here about exercise therapy, and this is from obviously a fairly stringent sort of review of a lot of the randomised controlled trials over the last 10 to 15 years. There is encouraging evidence that some patients may benefit from exercise therapy and no evidence that exercise therapy may worsen outcomes on average. So while we know that a lot of people don't respond well or have had bad experiences, say, with graded exercise therapy, I think we should remember that there are some people for whom it's actually worked. I'd like to probably get back to the basic concepts of graded exercise therapy and APT, because often it's not the concept that's wrong, it's the way it's applied. Graded exercise therapy is used a lot across other chronic conditions as well as CFS, and often quite successfully. And the concept really was that physical activity should begin at a very low level of exertion and then gradually increase in duration over time, but only as symptoms allow. And that includes the establishment of some baseline of exercise or physical activity that's actually achievable for the patient, followed by sort of gradual increments in the duration of the physical activity. Again, if you look at the APT or the energy envelope theory, that's also, you know, a fairly good concept, because it just means that people have a certain amount of energy with their condition. They need to set manageable daily activity goals and try and balance activity and rest to avoid symptoms appearing. And then hopefully that if they can manage symptoms and they don't get any increase in fatigue, they can gradually try and increase activity or exercise levels, but it has to be paced. But both those approaches are only successful if the programs are individually tailored to the client, so that sort of generic blanket approach just doesn't work. And it's also really important that clients have a setback plan. So if they are symptomatic or they're feeling ill, that's when they need to rest or they do no physical activity, or if they do or are physically active, it has to be very, very low levels. I often get asked by clients, well, why should I be physically active when I get so tired the next day? There are some, you know, reasonably good physiological benefits for trying to stay physically active, and certainly avoiding cardiovascular deconditioning, because there is a risk with that of some of those chronic lifestyle diseases like cancer and type 2 diabetes. What is also important is that being physically active helps avoid muscle wasting and the loss of bone density, because osteoporosis and the risk of fractures can occur in people as they lose bone mineral density over time. Being physically active, if you can, should also improve your cardiorespiratory and functional capacity just for doing activities around the house, or hopefully for getting people back to work or education. There's quite a bit of evidence that exercise or being physically active also helps manage stress, pain, anxiety and depression. And also improving sleep patterns, and that's something that's shown up with people with a whole range of chronic conditions as well as CFS. There's less evidence that exercise enhances some aspects of immune function, simply because the research really hasn't been done, and that was one of the reasons that myself and Roseanne actually did the study we did, because there's, you know, sort of literally no evidence out there in terms of exercise training. The sense of exertion, this is something that came up from Karen Warman's research 10 years ago or so. Possibly people that are physically active can reduce their sense of exertion, sort of like a resetting of their sensory threshold, and that might actually be beneficial because then being physically active is perceived as being less difficult for them. Looking at the evidence with exercise capacity, and a lot of this is, you know, relatively contradictory, so I'll try not to dwell on sort of the details too much, but I think the bulk of the evidence certainly shows that people with CFS have a decreased incremental exercise capacity, so that their peak VO2 and their heart rate and workload are often lower than sedentary or non-CFS people. There are a couple of studies that found no differences, but again, it depends on the type of client. You may have had people who were simply more or sort of fit and healthy and less symptomatic when that study was done. Lower heart rate and ventilation compared to non-CFS at each stage of a graded exercise test was something that came out of some of the earlier studies, but generally it's kind of assumed that people with CFS will have a higher heart rate, higher perceived exertion and higher lactate if they're doing an incremental exercise test compared to non-CFS. The more recent research is quite interesting because it looks at doing graded exercise tests on 2 consecutive days, which sort of may actually mimic people's physical activity in the real world a bit more. And they did find that people with CFS are usually unable to reproduce the same physiological measures on the second day. So in other words, their post-exertional malaise really stops them from achieving the same levels of incremental exercise. And they certainly will have a higher perceived exertion and be more symptomatic on that second day. There's not a lot of research been done sort of looking specifically at muscle strength, but Fulcher and White found that there was quadriceps weakness associated with poor cardiorespiratory capacity and certainly shorter test duration. Peak isometric strength is often decreased in people with CFS, and there was a fairly recent study this year that also looked at that with looking at hand grip protocols, and this was just looking at forearm strength, and found that less force was produced with a higher rate of perceived exertion with just a 3-minute hand grip protocol. Some of the reasons behind this, and again this is kind of debatable and some people may actually suffer from all these things, but cardiorespiratory can cause a lot of those physiological setbacks, and left ventricular dysfunction may be associated with people that have very, very low levels of cardiorespiratory fitness, but also autonomic dysregulation can affect those sorts of physiological outcomes as well. And there's also reasonable evidence that there are muscle biochemical abnormalities in people with CFS and also mitochondrial dysfunction. I will sort of briefly just cover some of the main studies that looked at graded exercise because I know there's a lot of controversy about that. The larger studies, certainly well funded, larger sort of cohorts I suppose, but also larger percentages of dissatisfied participants. And I guess the issue that I have as an exercise therapist is that many of the aspects regarding exercise were sort of not reported or not well reported, and I don't actually know, what did these people actually do and sort of what exercise intensities were set. The Ridsdale study is probably a bit better reported than the others, but I know that with the PACE trial, I think we know that people walked, but we don't really know sort of what levels they walked at, what their heart rate levels were. The smaller studies that often don't make it into sort of general publication perhaps, or they're not sort of quoted a lot, these are actually better described in terms of exercise programming. The Fulcher and White, Carper and Stasic, which is a very small study that actually had women with CFS exercising happily for 1.5 years and was incredibly successful. The Warman graded exercise therapy and stretching research study, Moss-Morris, Pardians, and the Gordon and Lubitz, those two studies were Australian ones that looked at adolescents with CFS, and they used a combination of strength exercise and some graded aerobic exercise and actually got really good results. So I'd probably encourage people to, rather than just sort of going back to the PACE trial, have a look at some of these other smaller studies as well, because they did get some beneficial effects from graded exercise. Looking at exercise modalities, aerobic exercise has kind of been reviled, I know, by a lot of people sort of following the PACE trial, but really, again, it's physical exercise that should be of a low to moderate or possibly up to a higher intensity that just relies on aerobic metabolism involving the large muscle groups. That's the ACSM, American College of Sports Medicine definition. Hayward and Gibson suggest that aerobic exercise is basically any large muscle group exercise that can be sustained for 10 minutes or more. And the evidence that's been done has focused probably primarily on walking, but also there have been some studies that looked also at people that chose walking, cycling or swimming, again with some benefits. If you look at the evidence and the research projects, the intensities vary an awful lot. So we've got some that go between, say, 40 and 70% of people's VO2 max or 40 to 70% of heart rate max. Again, that probably reflects the variation in the cohorts that participated, but I think the general recommendations are that if you're going to get anyone with CFS to do some form of aerobic activity, the intensity should be low to moderate. With strength training, it's really interesting that there's not been a lot of research done because by nature strength training is fairly intermittent, so people have sort of rest periods in between doing sets and reps. The Gordon papers looked at single set 8 to 12 repetitions, some upper and lower body exercises, core stability, but at very, very light to moderate loads. Progression as tolerated was recommended, and functional strength training such as balance training could be included there as well. But this is a real gap in the research, so it'd be great if people could do a little bit more research with strength training and CFS. The mixed model approach, where an exercise or activity session should have some aerobic and some strength components. Again, there's not a lot of evidence out there, but the programs or the research projects that looked at it found that it was generally quite well tolerated by clients. And again, that Carper and Stasic project went for 1.5 years with ladies that had CFS and fibromyalgia, and it was well tolerated. They sort of set their mixed model program up as circuit training, and again, little other evidence to support it, but they did find that walking, light resistance training, strength and balance and flexibility exercises were well tolerated over the long term. Looking at just flexibility training, it's been found to be effective for decreasing muscle soreness, especially when combined with other types of exercise. In isolation, it improved range of motion around the joints, but didn't really have much effect on fatigue. And more interestingly, I guess, some of the more sort of alternative types of exercise. There's been some recent research that looked at Tai Chi and Qigong for improving sort of fatigue and depression, and found that they were actually quite effective. And as you guys probably know, Tai Chi and Qigong are very sort of low intensity exercises that focus a lot on balance, stretching and range of motion. There's been a couple of projects that looked at yoga fairly recently and found that they seem to decrease fatigue and help with the clinical profile of participants. With aquatic exercise and hydrotherapy, most of the evidence is with fibromyalgia patients, for which it's actually recommended and is beneficial. There's no papers that I can find that have looked at CFS and aquatic rehabilitation, but actually my colleagues and I have got a small seed grant to research this, so hopefully that is a work in progress. Looking at intermittent exercise, and this is sort of where I got back to our research. Intermittent or low to moderate intensity exercise, where you're looking at, say, 1 minute of exercise, 1 minute recovery, has been used a lot in other chronic conditions, and it's sort of fairly established there, especially with conditions like chronic heart failure and pulmonary conditions. So there was originally a project by Clapp et al. That looked at intervals of exercise, treadmill walking, and found that there were no sort of exacerbated symptoms up to 7 days post-exercise bout. And we've recently just released a project results looking at intermittent exercise compared to graded, and found that both were reasonably effective and didn't exacerbate symptoms. I'd also wanted to include a little bit about that WorkWell CFS program that's run by Mark Van Ness, because that's been incredibly effective, and I get a lot of clients who follow that WorkWell program, and gives them a lot of benefits. And that's really looking at very, very small blocks of exercise or physical activity, say 2 minutes to 3 minutes, that can be just done once a day or maybe through the day, but are followed by rest, so symptoms aren't exacerbated there. Looking at some of the, or across all the studies, I guess the evidence in terms of whether home-based exercise is as beneficial as one-on-one supervised exercise, pretty much it is. But what is important about home-based exercise or being physically active is that there should be some sort of follow-up. And certainly, you know, constant communication with whoever is, say, the exercise trainer or a health clinician. That seems to lead to much better outcomes. Just looking at frequency and intensity, because there's often a lot of confusion about this. Looking at the current or the past studies, I'd probably recommend that people who are trying to be physically active certainly be very, very cautious, and maybe just do once or twice a week. And really, this only should be a progression to daily physical activity if the symptoms aren't worsened, and it may take a lot of time to get to that point. With intensity, it should be very much light to moderate, so certainly look at rate of perceived exertion on either the old or the new Borg scales, and it should really be in that very, very light to fairly light category. Heart rate, it should be combined with RPE, so it gives you an idea of the heart rate ranges together with your levels of exertion. But of course, heart rate range does depend very much on the presence of POTS or other cardiovascular issues, because unfortunately people with POTS have a very, very narrow band of heart rate where they can actually do physical activity without sort of bringing on tachycardia. Of course, the other thing to remember is that the intensity can fluctuate from day to day, and that depends very much on fatigue or pain, and whether there is any post-exertional malaise. In terms of progression, it has to be gradual, and this is something again that Fulcher and White and Karen Warman sort of published that it really should be somewhere between 1 to 3 minutes per week, if at all. So it should be very, very slow. Forget about that 10% progression per week that applies to people that don't have CFS, because it may very well exacerbate symptoms if you go down that road. Progression depends very much on fatigue and other symptoms, so again, be cautious. Session duration, I know that all the health guidelines recommend 20 to 30 minutes per day of physical activity to avoid chronic lifestyle diseases, but we know that people with CFS often just can't do that. So really look at starting off very, very low. Session duration can be as low as 2 to 5 minutes, and hopefully over time that can be built up. The barriers for being active, and I know that there are a lot of them, and certainly post-exertional malaise is one, together with recurring bouts of severe fatigue and illness, because we know that some people do get recurring symptoms. The daily fluctuation of symptoms is also an issue, so it's strongly recommended that CFS patients have like an activity diary or a symptom diary, so they can sort of note down how they feel on a day-to-day basis. The boom-bust phenomenon is something that really needs to be avoided. So we do have people that on the days that they feel really well try and do too much because they kind of want to make up for all the lost time, but that can exacerbate symptoms, and you can get into this kind of boom-bust sort of cyclic phenomenon, which is really not beneficial in the long term. Musculoskeletal pain is certainly a barrier for being active, and it's probably recommended that if you do suffer from that, just sort of gentle stretching and trying to maintain range of motion is one approach. I've found through clinical practice that often people are too tired to travel to a place where they can do physical activity. I've had patients that say if they drive for more than 10 or 15 minutes they're just exhausted, so that really puts them off travelling anywhere. So for clients that really sort of suffer from that type of exhaustion, some form of home-based program is probably beneficial. Other barriers, concentration and memory deficits, which are fairly common, and also financial and employment and education concerns, because I know that people have to try and prioritise their energy, so often that gets in the way of being physically active. But again, that sort of goes back to that sort of energy envelope concept, I guess, where you do need to try and prioritise things through your life, but hopefully being physically active gets in there somewhere. The actual medical red flags and contraindications for exercise. So anyone that is acutely ill, if you've got a temperature, swollen glands, fatigue or an increased white cell count, that is a sign of infection and or inflammation. So no, you shouldn't be exercising, you should be resting. The onset of any new cardiovascular symptoms like syncope or cardiac arrhythmias or tachycardia is also a red flag and really should be checked out medically. Severe musculoskeletal pain, again, a red flag, so if you do suffer from that and it's incredibly painful, don't exercise but rest. Severe headaches, especially the onset of new types of headaches, is something that should really be avoided, so don't exercise if you sort of suffer from those symptoms. The onset of any new neurological symptoms too is a red flag, so things like ataxia or anything that sort of maybe heralds some new neurological condition is certainly a red flag for doing exercise, as is the onset of more severe fatigue. Just with strategies for trying to get people to be physically active, and this is sort of obviously people that aren't incredibly symptomatic, encourage the use of fatigue or tiredness scales daily, combined with your rate of perceived exertion. So sort of looking at, is there a daily or weekly pattern of fatigue? How do people feel each day? What makes them worse? What makes them feel better? Certainly cease or reduce physical activity if symptoms are present, and that means don't push through symptoms. So set realistic goals. You know perhaps that you may get symptoms at various times, so expect those. There's nothing wrong with that. Expect the setbacks and have a setback plan. In terms of pacing, have a look at the time that's spent on daily activities and certainly prioritise the things that are important, and try and sort of balance the activities plus the energy use, and establishing daily and weekly routines for activity, rest and sleep is something that's been promoted not just by medical practitioners but also by exercise therapists as well. And I guess again, take home message, don't progress any sort of exercise if you have symptoms. Certainly a heart rate monitor is recommended for self-management or being able to take your own pulse in conjunction with RPE. If you don't have a heart rate monitor, then think about using the talk test as a sort of limit for how much you can do. So you should be able to be reasonably active and still be able to talk to someone. And if you can't, well, you need to sort of lower the amount of exercise or intensity. Just with cognitive strategies, some of the ones that crop up in the evidence, certainly having a physical activity plan and a setback plan, but also counselling and cognitive behavioural therapy are important. Certainly having positive feedback, being able to perhaps to change mindsets from being the glass half empty to the glass half full approach and trying to focus on sort of positive aspects of being active rather than the negative ones. And for people that do have problems with sort of memory and concentration and focus, if you're working with an exercise instructor or a therapist, then really instructions need to be fairly simple and very easy to follow, and distractions should be reduced. Just with this sort of summary take-home message here, I guess what I'm trying to say is that we know that there are degrees of severity within the CFS population that sort of really determine how much activity is achievable, and the activity needs to be appropriate because people with CFS know their symptoms. They usually know when they can be active and when they can't, and you certainly shouldn't be pushing past that limit. There is evidence that shows that exercise can help improve some physiological outcomes and depression, fatigue, cognitive function and self-rated benefit, but you know, really the take-home message is that it has to be low to moderate intensity and probably done in very short blocks. People need to be realistic in terms of their expectations and also need to individually pace their program, limited by symptoms. And again, I need to say that if you're acutely ill, you should rest. Don't try doing any exercise program if you're really suffering from acute exacerbations. And just backtrack. If you eventually feel better, then go back to easier levels of being physically active. Don't try and sort of start where you had to leave off. Intermittent small blocks of exercise certainly help maintain functional capacity, and we've found that they provoke less symptoms. And exercise may enhance some aspects of immune function, but again, this is a bit of an area where there's not a lot of research done. With CFS, most of the immune stuff has looked at effects after just a one-off bout of exercise and usually a maximal bout of exercise, but we don't recommend, obviously, maximal exercise for CFS patients, so we certainly need some larger studies. I just wanted to kind of lead into the research that I did, and I just wanted to try and summarise some of the exercise effects on immune responses because it's an area that doesn't get a huge amount of funding, and most of the funding tends to go to immune sponsors with high-performance athletes. But what they have found over the last 20 years or so is that looking at moderate intensity exercise with healthy individuals, and that includes healthy older individuals, moderate intensity exercise can increase the T helper lymphocyte function, so that's the CD4 lymphocytes, so their activation and also their proliferation, which means that they're able to respond to infective challenges better. The main mechanism seems to be an upregulation of the interleukin-2 receptor, plus there are some other receptors that are enhanced with exercise too. Enhanced production of interleukin-2 is very important because that interleukin-2 helps kickstart the immune cascade, so it actually has an effect on other T cells as well as B cells, and that helps with that fighting of infection. There's been a fair amount of research that's found that signal transduction within the cells actually improves with exercise. Improved natural killer cell function, a fair bit of data that says that, or has found that neutrophil phagocytic capacity is actually enhanced with moderate intensity exercise, although it might be suppressed with really high intensity or high volume exercise. And the other interesting thing recently is that they found that being physically active helps increase the action of telomerase, which is an enzyme that maintains the telomere lengths on chromosomes. If your chromosomes remain fairly long, then there's less chance of them actually mutating and being sort of a risk or a cause of cancers down the track. So maintaining telomere length as you age can be quite important. And there is further evidence of enhanced lymphocyte function with moderate intensity exercise with some of the other chronic diseases. HIV, there's a fair bit of evidence out there, and also for cancers, most notably breast cancer. And I have included this diagram down here. This is the J curve, which has been used a lot over the decades. It was originally put together on evidence for upper respiratory tract infections, and what they found is if you look at the bottom of the J, that's moderate intensity exercise, so there's a much lower risk of infection if you exercise moderately, but if you do the really high intensity stuff, that tends to be immunosuppressive, and unfortunately though, if you're totally sedentary, that can also be immunosuppressive. So I guess what I'm trying to say is aiming for that low to moderate intensity physical activity may actually be beneficial for your immune responses. Which kind of leads me into our study. The second paper actually, in terms of exercise, was published in Medicine, Science and Sport and Exercise earlier this year. But we looked at 12 weeks of intermittent exercise compared to graded exercise therapy and no exercise with T helper cell lymphocytes. This is a pilot study. We didn't get large numbers, unfortunately, so I'm sort of fairly cautious with discussing, the results. But it was a randomised controlled trial. We had a graded exercise group, intermittent exercise, the usual care or non-exercise control group, but we also compared the blood and immune indices to a non-CFS group that were age matched. We did pre and post intervention graded exercise tests to volitional exhaustion, so that was the VO2 max test. We also did blood tests and immune cell analyses and fatigue severity scores pre and post. The program itself was 12 weeks and it was just cycling 3 times a week. With very, very short sessions to start with. We had an unloaded 5-minute warm-up, about 10 minutes of exercise and then a cool down, so actually it was quite sort of short duration. We looked at heart rate, blood pressure, RPE and oxygen saturation during each session, and the clients also did daily tiredness scores and kept daily diaries which were collected each week. In terms of the exercise intensity, the graded exercise was at 50% of their VO2 peak, so that was quite low to moderate, and the intermittent exercise, they had 1 minute 30%, 1 minute at 60% VO2 peak, and then that was sort of repeated. So it really was 1 minute intervals with sort of the rest interval in between. In terms of the immune indices we looked at, 4 blood counts. We looked at just the circulating immune cell subsets, which included lymphocytes as well as the other leukocytes. We also specifically looked at T helper cell lymphocytes because they're so important with the whole immune cell cascade. This was looking at cells that were stimulated and incubated to see how they'd respond to challenge. So we looked at the T helper cell CD4 lymphocytes, the interleukin-2 receptor expression, and also OX40 or CD134 is another activator of T helper lymphocytes. We also looked at cytotoxic lymphocytes, that's CD8, CD38, and natural killer cell function, specifically the LAMP1 and 2 receptors, which are measures of perforin. So natural killer cells work by being able to degranulate or actually lyse other cells and then degranulate, sort of killing tumour or virally infected cells. So we looked at the receptors responsible for the perforin release. And what we found, this is just the exercise, or I guess the aerobic capacity results, and looking at the test time pre and post. I guess what was most significant was whether you did graded exercise or the intermittent exercise, there were still significant improvements in aerobic capacity, so VO2 peak. The elapsed test time, we just missed out on significance with the graded group, but there was certainly, up to 2 minutes increase over 12 weeks in elapsed test time, which is really quite significant for people that do have chronic fatigue. We also found that the anaerobic threshold, the VO2 and the time taken to get to anaerobic threshold increased significantly. Again, it didn't matter which type of exercise you did, so both of them were able to improve aerobic capacity significantly. Just looking at fatigue and tiredness scores, and this was quite interesting because the fatigue severity score, that questionnaire, the results didn't change for either group, either before or after. So in other words, they felt fatigued coming into the study and they said they felt fatigued at the end of it. But the tiredness scores were a bit different because they were rated 0 to 10, so no fatigue and excessive tiredness. What we found that compared to the beginning, the week 12 tiredness scores were significantly higher in the graded group, but not in the intermittent group. And then when we looked at the tiredness scores 24 hours after their exercise session, again it was significantly greater in the graded group, but not with the intermittent group. So I guess what I'm trying to say is that the intermittent exercise was less tiring, had the same beneficial physiological effects, but was certainly less tiring for the participants. And just kind of to finish off, this is just taken from the MedSci article. This was just looking at the immune cell results. So up here in number A, the black bars are the control group, so the non-CFS, and certainly prior to doing any training, all the CFS patients or clients had much lower numbers of T helper lymphocytes, but this was increased after exercise. So the hashtags there show that significant difference compared to baseline. So both the graded and the intermittent exercise groups significantly increased their T helper cell concentrations. Looking at the interleukin-2 receptor, again, both groups managed to increase those with exercise training, and that's something that has cropped up with non-CFS people as well. The results are probably less clear for the OX40 or the CD134. It only seemed to be the intermittent group that showed those improvements, but probably the most important is number D. These are the cells that show all the receptors, so this is really the crux of it. We found that the graded and intermittent groups increased the T helper cells that showed all those activation markers, which means that they're in a much better state to fight any sort of infection. So it seems that either type of exercise modality has these beneficial effects for T helper lymphocyte activation. So just with the results and conclusions, just post-intervention for this particular study, increased CD4 activation markers and concentrations of T helper cells. We didn't really find any changes in the CD8. I haven't written the paper or published the paper on this yet, but it's sort of in the works. But we didn't really find any changes with CD8. Again, that's something that also shows in various other studies. It seems to be a bit of sort of contradiction there. No one's quite sure why. We did find that natural killer cell function, or this receptor expression of LAMP1 and LAMP2, increased, which suggests that natural killer cells are better able to function and again to sort of fight virally or tumour-infected cells. Both intermittent and graded exercise improved aerobic capacity, but overall the intermittent exercise was a lot less tiring, which means that it may be a better sort of approach to use compared to the graded exercise. Okay, and that's pretty much it. So I hope I haven't rushed through that too much, and certainly would appreciate any sort of discussion or questions if anyone would like to ask.
Wonderful. Thank you very much for that, Suzanne. I do have a couple of questions that have come in already. There was one person wondering if you have examined sex or gender differences in your research, particularly in regards to the evidence of exercise benefits and outcomes.
No, well, this particular project, we didn't have the numbers. We only had 8 in each group, which means it's considerably underpowered, and that's why we sort of really classified it as a pilot study. Ideally, if we have larger numbers, I'd have to look at the genders separately, and that's something that's important for the say the VO2 and the exercise test results as well. And that is an interesting area. I'd love to be able to do a sort of much larger study on this and actually be able to have the separate pools of males and females and to see if there are any gender differences with the various immune indices there.
Okay, let's see. Then someone was wondering, someone has CRPS and degenerative disc as well as fibro, along with CFS, but mostly up in their neck and shoulders, and wondering if doing exercise to work on the legs while the heart is to get the heart pumping, even though there's pain in the shoulders, is okay, or if you recommend not doing it at all because you have pain and inflammation in one area of your body.
Okay, it's an interesting one. I think I don't know what sort of, or if they've been seeing a health practitioner about the neck and shoulder problems, but I would probably recommend trying to just do very gentle stretching and range of motion for the upper body. If they're able to, say, do recumbent cycling or do a bit of walking perhaps that doesn't exacerbate the upper body, that would be maybe beneficial. There are probably some sort of really gentle lower body strength exercises that perhaps could be done, sort of gentle squats and lunges perhaps, that doesn't really involve a lot of sort of massive postural changes in the upper part of the torso. I think maybe try those various things and just see if any of those exacerbate the upper body problem. I'd probably recommend that, this person probably is already getting some form of therapy or massage for the upper body issues, but if that pain can kind of be reduced, then there's possibly a greater chance of being able to do some of the exercise that involves, the lower body or the larger muscle groups in the lower body that are beneficial.
Great. Let's see, then there was someone else wondering, they have a large home where they do most of the housekeeping activities each day, and by the time they're finished doing that, it's hard to have the energy to then do exercise. Wondering what your thoughts are on housekeeping activities versus like a graded exercise program, and anywhere to like intertwine the two or make them, more compatible.
Yeah. Look, I quite understand that doing housework takes a hell of a lot of energy, especially vacuuming. It's horrible. I think if you can plan your housework activities, and if you're involved with, sort of going through changes in say, body position, where you're doing activities that actually are using squatting and lunging perhaps, or certainly walking around the house pushing a vacuum cleaner, that, that's kind of comparable in terms of metabolic load. That's kind of comparable to doing, walking anyway. So what they could look at doing perhaps is trying to break up the house activities during the day to make it less tiring. But you can include some, really functional movements, just doing housework. So standing at the sink, washing up, just being able to do little squats and lunges, or get up and do some calf raises and things like that. That's, that's working your muscles. But it may be less tiring than sort of having okay, I've now got to do half an hour of brisk walking or whatever. So I think if you sort of are able to split it up during the day, you probably get the same metabolic costs as maybe just doing a half hour of walking or sitting on an exercise bike.
Wonderful. And then someone asking, what percentage of your patients experience PEM, and how did you determine the presence of PEM?
Okay, they all had post-exertional malaise because they all came into the study saying they were fatigued, and they all had that. The program, they only did their cycling every second day, so it was only 3 times a week. So they had a recovery day, and that was one of the reasons we got them to do the diary, because we needed them to record their tiredness and fatigue and any symptoms 24 hours post. We did a follow-up too, by the way, when we did their initial VO2 max test, we rang all of them and sort of asked, well, how are you feeling? Most of them, it was interesting, most of them said, well, I felt tired, but actually looking back on it, I could have gone harder during the VO2 max test. So I think they kind of paced themselves. They did what they thought was a maximal effort, but they all sort of said, well, we actually could have gone harder, and we're not as tired as we thought we were going to be. So there was some PEM there, but not as much as expected. And what we tried to do with the program is get them to really monitor the post-exertional symptoms, and we cut the program back, or we just didn't progress them if the symptoms were severe. And it was very interesting at the end of the study where we got very few dropouts. They said they felt that they actually managed their PEM really well. It was better to try and break the program up like that, to have a rest day in between. So we didn't do 2 consecutive day CPATs. I have some issues with that. We actually had some clients that were very symptomatic. We had quite a few that had severe fibromyalgia, and they weren't keen, they wouldn't have been keen on doing that anyway. And really for us, we weren't trying to look at maximal exercise 2 days in a row, because the program wasn't maximal exercise. Ours was very low intensity, and that's really what I think, CFS ME clients should be doing. So we just did the one-off test. We asked them to check their PEM and give us a sort of a figure, like a 0 to 10 figure the next day, how they were, and we just very carefully got them to monitor how they felt through the 12 weeks. So any excessive symptoms, we cut them right back, and they sort of progressed as symptoms according to symptom limits.
All right, and then someone asking what kind of professional you'd go to get an exercise program, like an intermittent exercise program or a graded exercise program?
Oh, that's really interesting, because I don't know what the health system's like in Canada. In Australia, clinical exercise physiologists, it's actually an allied health profession like physiotherapy or occupational therapy, and we're part of the Australian healthcare system. So chronic fatigue syndrome and fibromyalgia are actually one of the target pathologies that people get trained for. I would probably suggest if you know of a sympathetic physiotherapist perhaps, or an allied health practitioner who deals a lot with people that have chronic pain, that would probably be the best person to go to. I have, I suppose, worries about people that are just sort of general personal trainers or fitness instructors who may not understand perhaps enough about the pathophysiology. And of course, you can go to your doctors and GPs, but often they don't have exercise training. So that also makes it difficult because they might say, well, you know, be physically active, but they don't quite understand how to do that. I think, you know, the Mark Van Ness program I think is actually very good, where you're just working with, say, 2-minute blocks of physical activity during the day, or you could just look at, you know, pacing yourselves and set aside maybe 5 to 10 minutes, just do 1 minute of very gentle exercise, 1 minute rest, 1 minute gentle, and just sort of keep a track of how much you can do without exacerbating the symptoms, and that kind of gives you your baseline of how much activity you can do.
Great, and I can also do some looking into what the setup is in Canada, even just to get a brief overview so that people might have a better place to look for that as well.
Yeah, look, I think in the US they also have exercise physiologists there, and the American system may be slightly different, but I'm sure that there would be exercise therapists and specialists there who probably do specialise in CFS and ME and other chronic pain conditions. So it's probably, you know, need to sort of word by mouth perhaps, or sort of go to some of the support groups perhaps that maybe have a list of practitioners who could help.
Right. Yeah, that's a good idea too. Let's see. Someone wondering about if you do anything around diet, just in the sense of how it relates to the exercise program.
Yeah, look, I actually haven't done a huge search on sort of diet and CFS. I guess the recommendations would be to follow as healthy a diet as possible. And certainly if you know that you're low in some minerals and vitamins, to take supplements. It's an interesting one. I've had people ask, is perhaps a high carbohydrate diet better in terms of glucose uptake and that sort of thing. I don't know. Again, possibly there are dietitians that specialise more in this sort of thing. I just haven't done a lot of searching on it, and I'm not a dietitian myself, so I sort of feel a bit hesitant about giving nutritional and dietetic advice. I do know that in terms of, you know, taking really mega doses of vitamins and supplements isn't particularly effective. There doesn't seem to be any evidence that actually works. I just think if you follow a simple diet, if you have food intolerances, then obviously don't take those foods, but keep it sort of simple, not a lot of processed food, and just make sure that you do have some protein or lean protein, some carbohydrate, and you do have to have a little bit of fat in your diet, and probably avoid processed foods would be a good recommendation.
Someone who was asking about, they used to have really bad bouts of PEM, and then recently they went on a bunch of underwater dives, like deep sea dives, and that seemed to actually help the PEM while they were doing it, and wondering if you know of any positive effects with nitrix 32 and an increased partial pressure of O2.
I have absolutely no idea, but that's actually really interesting. Does the person have POTS or any sort of autonomic issues? I'm just wondering whether the changes in pressure there may have had something to do with that and sort of helped improve that. That's actually really interesting. I haven't heard of that before.
I will wait for them to respond, and then I will say whatever their response is.
Okay.
In the meantime, let's see. The woman did say no, she does not have POTS.
Oh, okay. Oh, that's really interesting. I honestly don't know, but that might be a interesting avenue for future research for sure.